It's my pleasure this afternoon or morning or whenever you are listening to us to welcome you to our podcast channel, which is tagged Cancer Research Africa. In this channel, we're going to be reviewing research activities in Africa, which are geared towards controlling cancer upsurge, avoiding on the continent. And we'll be featuring standing African investigators who are making giant strides in this regard. So in this maiden edition, we will be reviewing the landscape of cancer research in Africa, particularly as highlighted by the Lancet Commission on Cancer in Sub-Saharan Africa. This afternoon or the morning, whenever you're listening to us, I'm excited to be joined by two outstanding researchers. And just before I ask them to introduce themselves, myself, I'm Professor Solomon Rotimi. I'm a professor of clinical biochemistry at Covenant University in Nigeria. And I'm also the co-chair of the Aortic Research Committee. It is indeed my pleasure to welcome you. So to start off, Professor Zakari, may I request that you briefly introduce yourself, please.
Good day, Professor Rotimi. Good day, colleagues. I am Professor Zakari Mohammed. I'm a professor of pathology at the Bayero University in Kano. I'm also a consultant pathologist at the Aminu Kano Teaching Hospital, Kano, and currently the principal investigator for the Prostate Cancer Transatlantic Consortium in the AKTH chapter. My research interests are mainly in genitourinary pathology, specifically cancers. It's nice to be with you. Thank you.
Thank you very much, Prof. We're excited to have you here with us. Next is Dr. Catherine Oladoynibo. Dr. Oladoynibo, please.
Okay, my name is Catherine Oladoynibo. I'm a nutritionist. My specialization is in community and public health nutrition and also in behavioral science, basically in management, using behavior to manage non-communicable diseases. I work at the Department of Nutrition and Dietetics, Federal University of Agriculture, Abeokuta in Nigeria. I'm the Center PI for the Prostate Cancer Transatlantic Consortium, FUNAB, and I'm also the Director of the African Behavioral Research Center here in FUNAB.
Yeah, thank you very much. That happens a lot. So just to give our audience the background. So the discussion today is going to be on Nigeria. So we brought to you this time two investigators looking at it from the clinical and the pathology perspective to the behavioral and social science angle. And this is so important because cancer is a complex disease. And so if you look at Nigeria itself, based on this Lancet Oncology, Nigeria accounts for over $5.6 million annual economic loss and over 2 million disability adjusted life years based on the data gotten from 2019. And so this makes Nigeria to be one of the most negatively impacted countries economically in this region, in the sub-Saharan African region. But it's not all that bad. Nigeria has made several vital progress recognized by this commission in controlling cancer within the population. And this includes advances in implementation of hepatitis B, birth dose vaccine in alignment with WHO region resolution, and also championing development of viral hepatitis national strategy with the ambitious goal of eliminating hepatitis by 2030. This is a huge progress. We also know that Nigeria has made huge progress in controlling tobacco consumption. Although we know this is on the rise, but the effort is commendable. As far as the research perspective is concerned, this progress is limited by several factors. Among them is the dearth, the low, the shortage of pathologists available per population, per Nigerian population. Generally, if you look at sub-Saharan Africa, based on the data presented in this commission, what we have is that you have one pathologist per 1 million population. Now, this is compared to 1 per 8,000 in the UK or 1 per 20,000 in the US. Nigeria, you look at the population, it's maybe 1 to more than 1, one pathologist to more than 1 million in Nigeria. And so we're going to start off our conversation on that from that angle, Professor Zakari Mohammed. So here is the data staring us in the face, presented in this Lancet Oncology Commission. You as a leading pathologist in Nigeria, and someone who is also involved in administration of medical practice in the country. What is your perspective about this data?
Okay, thank you very much, Professor Rotimi. The Lancet Oncology Commission have done a beautiful job by bringing to the fore some of the very unfortunate statistics about the workforce of oncology workforce in sub-Saharan Africa, including Nigeria. Regrettably, as far as the pathology workforce is concerned, the statistics are very appalling. As you rightly observed, the ratio is more than one pathologist to over 1 billion population. In fact, there's a 2015 report that showed that a particular West African country at that point in time did not have a single pathologist, and you see the ratios vary. Nigeria is on the higher level of the spectrum with this 1 to 1 million. Other countries like Malawi, you have about 1 pathologist to 3 million population. So that is the reality. The numbers are very low, and even where they are available, the workforce is not evenly distributed. It's concentrated mainly in the urban centers and in a few tertiary or secondary facilities and high-level private facilities. So there's inequitable distribution of even this small number that we have. So fortunately, that is the reality with which we are faced with.
Well, it's interesting that you, beyond and agreeing with the Lancet data, you also, pointed out to the equitable distribution of these pathologies, that there are people in the rural area who don't even have access to this medical expertise. Now, so the question then becomes, what are the factors that are responsible to this low shortage and also inequitable distribution across the country? And as you begin to also respond to that, what can we do, to mitigate this shortage?
A number of factors actually are responsible for this very small numbers and then the inequitable distribution. I'll be quick to point out that this small or low oncology workforce is not peculiar to just pathologists, but affects also a couple of other specialists in the oncology space, including the radiation oncologists and other hemato-oncologists, oncology nurses, etc., etc. But squaring down on the pathologists, one of the main reasons why we have the low number of pathologists is that not many graduate medical doctors actually show interest in specializing in the area of pathology. So this evolves from the medical curriculum, which has a relatively low contact hours between pathologists and the undergraduate medical students. So the way the curriculum is structured, they have a relatively limited time that they spend in pathology and other spheres of laboratory medicine compared with the other clinical departments of medicine, surgery, pediatrics, and obs and gynae. So, and there are clear studies that have shown that this is partly responsible for why when they eventually graduate, these students do not show interest in specializing in pathology. In years past, the government have tried to create some incentives to encourage graduates to specialize in such areas like pathology and anesthesia and a few other areas where generally you have the lowest workforce in the healthcare sector. So unfortunately, these incentives have since been rubbed away. They are no more in place. So based on that, we have a low number of graduates that show interest in specializing in these areas. This again is coupled with the fact that we have a limited number of training centers, accredited training centers, again, where even when these graduates want to enroll and specialize in this area, you have a limited number of training centers which are accredited, which have the requisite workload, the turnover, sample turnover that is required for proper training so that the pathologist could be at least international standard. This training should be at least of the international standard. So there's a minimum number of sample load that is required at the training center. So we have limitation in the number of centers that actually where these pathologists are going to train. In fact, as it is, based on the number of graduates that we are presently having, we graduate less than 80 pathologists in the whole of Africa every year, because this is speaking of the whole of Africa. So we want to attain those statistics you are quoting in the United States or the UK. It will take us almost about 400 years to reach that level at the current graduation of 80 pathologists per annum. So actually there's this limitation of the training centers, again, where pathologists are training. Then even as we are training, again, the attrition rate, again, is high. Some are retiring from service. A few are dying off. Many are migrating to the diaspora again. So this again further compounds, even with the low numbers that you have, again, you're having these other competing factors again, which are depleting numbers. So there's a great need actually to invest in seeing how we can build capacity and encourage more practitioners to actually move into the sphere of pathology and specialize in those areas by opening up more training centers that would be accredited, and again, seeing how we could also collaborate with colleagues internationally to see how they could support the training. I think there are data to clearly show that in some of these initiatives that have been done in a few countries or centers have actually helped to improve the pathology workforce by this North-South collaboration in the training of pathologists. This again is another thing that could help. Of course, issues like virtual training again has come to the fore in the last few years, but credit to the COVID-19 pandemic. Virtual training has become a topical thing. So pathology again has not been left out. There's virtual pathology or telepathology, which again is a modality of training, or where you could be able to train residents from all over the world from a particular center.
That's clearly something that we need to begin to look at how to take advantage of. But just before I let you go, another thing that was pointed in this commission is sufficient population-based registry. Do you think that the low level of pathologists also contributes to this?
Yes, of course, there's a relationship between the low number of pathologists in the country, again, with limitations of the population-based cancer registries, because one of the main things that determines the quality of a cancer registry is the proportion of histologically verified cancers that you have in that registry. So definitely, for a cancer registry to be optimal, you should have a greater proportion of the cancers imputed into that registry being verified by pathologists, where you have a clear histopathological diagnosis. So, of course, indirectly, it also impacts on that, because as it is, we have a very limited number of population-based cancer registries in Nigeria. You could virtually count them in the fingers of one hand. The majority of the cancer registries are actually hospital-based cancer registries, and definitely for us to make headway as far as cancer control programs are concerned, there's need to strengthen our network of cancer registries.
Thank you very much, Prof. I will use that to then lead us into the other angle that this commission, brought into this conversation about, population-based cancer registry. And so, yes, we know that because we don't have enough pathologists to diagnose, perform the histological diagnosis of this disease, yes, because of that sort of tied into low level of population-based registry. But beyond that, it's also the poor health-seeking, healthcare seeking behavior of the population. And that leads us to Dr. Oladoynibo. And so what do we understand as the behavior of an average Nigerian as far as seeking healthcare is concerned?
Thank you, Professor Rotimi. So when you talk about health seeking behavior, basically in Nigeria, there are three different facilities that Nigerians go to seek health. When there's a health problem, is that they go to the orthodox clinic, or they go to the traditional healers, or they go to a faith-based institution. So, and when you talk about where you find most Nigerians going to, there are factors that dictate which of these facilities they will attend. Several factors like the level of literacy among the population of an individual will determine whether he will go to see a doctor in the hospital, or he will go to see the traditionalist, or he will go to see, to the church or to the mosque, for prayers when there's a health challenge. Another major factor is our culture. Basically, because Nigeria is a very religious country, it's in our religion is part of our culture. And so seeking health with the traditionalist, which includes the traditional birth attendants, the soothsayers, the midwives, and all of them. So you have a lot of people in this category. Even for mental health, people go as much as seeking health from some of these traditionalists. So culture is a main factor that determines the places where people go to seek for healthcare. The health services, the healthcare service, the orthodox healthcare services itself is a major factor in determining where people go to seek health. One of the reasons why most people may not want to patronize the orthodox clinics is because of the cost, majorly because of the cost. Most Nigerians are not on the National Health Insurance Scheme, especially in the rural areas. And so because of that, if they have to pay out of their pocket, especially for cancer treatment, then, which is very expensive in this part of the country, you find out that most people will not go to the clinic. They will rather go to health, to go to the traditional healers or go to a faith-based institution. Most of the time, these healthcare facilities in the rural communities are very far. Okay, so you will not find a secondary healthcare center or a tertiary health center in the rural community. Most of them are in the urban centers. And so when there's a health challenge, they will rather visit, the traditional healers. Most of the time when people come to the clinic, based on what Professor Zakari just said now, because of the field, you have clinicians, the ratio of clinicians to the patients, is very low. You have a lot of patients, and you have very few clinicians that want to attend to them. So the waiting time at these health facilities is also takes a very long time. And so because of that, you find that most of the patients, would rather prefer to seek help from somewhere else rather than going to the clinic. And most importantly, most of our doctors are migrating out of the country. Our health professionals are leaving the country. And so this makes the situation even worse, than what it is before. So we have a whole lot of challenge, in our hands to deal with.
Yeah, so we know that one of the, your area of expertise is in implementation science. And I'm just wondering, so what can we do to influence change in this behavior? We know it's not going to change overnight, but a little step at a time, that is still progress. What do you think we could do to improve this behavior?
So the first thing where we need to start from is to increase awareness. We need to increase awareness among the population. We need to educate the population, and we can do this. One of the things I believe, ways in which we can achieve this. The community health practitioners, the community health workers are the people who work at the grassroots. And most of them are not the capacity to educate the population, on why they need to seek help from the right place, from the orthodox clinic. They don't have that capacity. So where we need to start from is to begin to build the capacity of our community health practitioners, the community health workers in all our different health centers. We have a lot of them across all the health centers in Nigeria. You'll find those health centers in the rural areas, okay? Just like you will find them in the urban areas. But the people you will find there are the community health workers. So when they are empowered to educate, to give the correct information, to the population, then they will be able to do that. So we need to start by educating the CHU, that's the community health workers, to be able to educate the community appropriately for them to be able to seek health in the right places.
I agree with you. Education. We need to do community engagement through these, community health workers, so that they can begin to identify, know when to go for screening based on their age, based on their risk factors, based on their occupation. And with that, we should be able to begin to pick up, this, forms of cancer early enough. Dr. Oladoynibo, that's a very beautiful, perspective to it. And so finally, before I let you go, because of your expertise in implementation science, I'm just wondering, there are diverse, discoveries that have been made into how cancer can be controlled. Talk about exercise, diet. Now we know that the diets that have been, worked on in other populations are not exactly the same diet that we have here. Okay. So the question is, how do we domesticate some of these, findings? How do we implement it for cancer control in Nigeria? I mean, what's your perspective or your idea? What's your take on this?
Thank you, Professor Rotimi. So we have imported a lot of ideas and a lot of findings, which we as Africans, we sit down to identify our problems ourselves and come up with solutions that is Afrocentric, for Africans ourselves. Come up with research. We need to do research that is Afrocentric. We need to come up with ideas. We need to come up with findings, that can help our population, rather than always basing all our treatment, all our ideas and research on what has been done in the Western world. This is not going to really help us. So we need to sit down, do a stakeholders analysis, come up with what we need to do, which way forward. Some of those researches are wonderful that have been done. Some of them we can implement, but some of those things will not work for us because this is a different climate entirely. And so for us to be able to come up with solutions to African challenges, especially with cancer problems, then we need to sit down and do our own cancer research in such a way that we will be able to come up with results and solutions that can help address cancer problems in Africa.
Yeah, I totally agree with you. And one thing for us to do our own research, to move it forward at its rate and speed at which we want it to move, it's also limited by how much does the average Nigerian know about the benefit of cancer research. And that touched on what the Lancet Commission mentioned about the importance of patient education about cancer research. I'll go back to Professor Mohammed. Prof, how do you think we can better educate patient population about the benefit of cancer research to the society? Because you meet the patient, this is a very horrible disease, and they're going through a lot, financially, emotionally, and sometimes spiritually. So how do we overcome this barrier and be able to educate them about the benefit that the society stands to gain from their participation in cancer research?
Basically, what we need to do, of course, is to find strategies that we would use to educate the patients actually about their disease conditions, which in this instance is cancer, and then to make them understand that there's a lot of genetic basis to some of these diseases, and we need these research outputs to be able to determine what modalities of treatment work best for people in our own environment. It's clear that most of the data that we are working with in this age of precision medicine were derived from data in the high income countries, where there are a lot of differences between their genetic makeup and own genetic makeup, particularly here in sub-Saharan Africa, where we have a widely diverse genetic composition. So we have to let the patients know that it's only from research outputs from utilizing our indigenous populations in Africa that we actually come out with real answers to our own research questions and be able to devise appropriate therapeutic measures for our own cancers here in Africa. The ones with, yes, it's good that so many of the therapies are developed from research in high and middle income countries, but yes, we need a lot of input from our indigenous populations in sub-Saharan Africa to be able to come up with these peculiarities that our own cancers have. And clearly, recent research has clearly demonstrated a lot of these things, and our patients need to understand. And if they understand that, I think they would be more willing to participate in various researches, including clinical trials, to be able to come up with therapies that work best for patients in our own environment. So this aspect is key for us to develop these strategies to enlighten our patients. Thank you.
I agree with you absolutely, Prof, because I've spoken to patients, and one common question is that, why did I have this disease? And it will be of interest to let them know that their participation in research will help us provide better answers to such questions like that. I really want to appreciate, both of you for taking our time today to be part of this podcast. What is important is that, in conclusion, we need, as a country, to understand that cancer is a multifactorial disease. And it is important for us to, continue to engage in research to close the gaps that currently exist and have been clearly identified by this commission. We know there's the contribution of environment, there's contribution of lifestyle, there's the contribution of genetics, which is very important. And also the commission understands, I highlighted that, Professor Zakari also touched on that, because all come together to determine the outcome that an individual, has or come up with. So this is a call for action on developing cancer cohorts. So we need to begin to structure the system that we have, organize ourselves better, that we can now follow even our patients. We will not just be looking, retrospectively, we'll be able to do prospective longitudinal study to better understand the impact of environment, lifestyle, the biology, and all of this come together to result in the disease that we consider as cancer, and also to improve the clinical outcome. It's been a very nice time discussing with both of you today, and I just want to appreciate you, Professor Zakari and me and Mohammed, for taking out your time to be part of this discussion today, and also Dr. Catherine Oladoynibo. Thank you very much to both of you, and continue to have a very nice and pleasant day.